Bismillahirrahmanirrahim. Hi everyone. I thought about creating an eighth video just to kind of go over most of the what we talked about before and most of the common causes of hyponatremia and their finding and their management in this short video instead of doing that in the previous video when we talked about the management. So okay, let's do it. Alright, so this is a table to go over the most of the common causes of hyponatremia, the underlying etiology, the basic clinical features, the basic labs, and the key features in the management. The colors kind of represent some of the groups. So these two are the non-hypoosmolar hyponatremia. The rest are the hypoosmolar hyponatremia, and the one in the next slide too. The basically these are the two causes of hyponatremia for which we do the measured serum osmolality to make sure that it's low, because it can be high in translocation on hyponatremia, and this is usually due to diabetes complications including DKA and hyperosmolar hyperglycemic state, or use of mannitol in the ICU or glycerin in the surgery, which are less common than the diabetes complications. In these patients, again, the measured serum osmolality will be increased instead of being low. We mentioned that it should, with most of the causes of hyponatremia, if it's true hyponatremia, the measured serum osmolality should be low. It should be high in this case. And if it's due to hyperglycemia, then the glucose level should be high, and then you treat the underlying cause and you can correct the hyponatremia based on the exact glucose level. And if the measured serum osmolality is normal and it's not low, this could be due to pseudo hyponatremia or false hyponatremia, and this usually happens with patient with increased proteins, paraproteins like in multiple myeloma or hyperlipidemia. So the patient might have some clinical features of these conditions. Again, the measured serum osmolality will be normal, and serum sodium, if you do it in the ABG machine, can tell you the true the true sodium level, and you need to communicate with the lab to see if they use a method that led to the development of the pseudo hyponatremia. And in this case, you just ignore the serum sodium because it's not true. After you confirm that it's not true, and after you check the actual one, and look for underlying cause and treat it. Okay, after you confirm that the measured serum osmolality is low, if the patient is showing signs of hypervolemia, it's most likely one of these three: heart failure, cirrhosis, or kidney disease. So in heart failure, the patient might have feature of fluid overload, features of cardiac disease, urine osmolality will be increased because of increase in the ADH, and urine sodium will usually be low because of decreased or the effective relative effective hypovolemia, because the kidney will perceive the status of the volume of the patient as being low because of the low cardiac output. But if the patient is taking diuretics, then the urine sodium will be high. Water restriction, you can try that when the patient is having heart failure with hyponatremia. Patient on heart failure exacerbation without hyponatremia, sometimes or most of the time you might not need water restriction. You will need salt restriction. But if there's hyponatremia, you need both salt restriction and water restriction, and then initiate diuresis and initiate the management of the underlying cause, which is heart failure in this situation. Patient with cirrhosis also might have features of fluid overload, and may have features of the chronic liver disease and features of the underlying cause. Urine osmolality expected to be high. Also, urine sodium will be low for the same reason here. But if a patient is using diuretics, then urine sodium will be high. That treatment, of course, the treatment of the underlying cause and water restriction also. Patient with endothelial disease also, especially if it's advanced, they might have a feature of fluid overload. Urine osmolality is expected to be high. Urine sodium is variable, but usually high if a patient is having tubular disease and damage from the underlying cause. In nephrotic syndrome, might be low. And then the treatment again also is to treat the kidney disease, dialysis if there are end-stage renal disease, treat the nephrosis if they have nephrotic syndrome, water restriction as well. These are the hypervolemic hyponatremia. And these two in yellow, they're kind of common or the causes of hypovolemic hyponatremia. The most common one is being the non-renal loss, including GI losses, which is probably the most common, but also skin losses and bleeding. Now, again, these are causes on bold tables. They are the ones which are more common. So hyponatremia was non-renal loss. Patient might have features of hypovolemia, dry skin, dry mucous membrane, dry axillary skin, borderline vital signs, and all that. And we talked about the sensitivity and specificity of physical examination and point of color ultrasound in assessing volume status. So go back to that paper and narrative review to look into it. We mentioned that in a previous video. The urine osmolality will expect it to be high. Urine sodium will be low because the kidney is trying to retain sodium in an attempt to increase the volume. Fluid replacement is a treatment. You fluid resuscitation and treat the underlying cause of the non-renal loss. This is a much less common cause of hypovolemic hyponatremia, which is cerebral salt wasting or renal salt wasting. Renal salt wasting is more common than the cerebral salt wasting, which is really rare. A patient might be hypovolemic because of loss of sodium and water from the kidneys. Signs of the underlying disease. They might be sick in case of cerebral salt wasting. Urine osmolality expected to be high. Urine sodium is also expected to be high. And this is a case here with this condition and also with conditions that mimic SID, including SID itself. And these are the causes ingredients. So these are the causes which are associated with increased urine sodium and urine osmolality. Now, with renal or cerebral wasting, you treat the underlying cause. Patient if they're sick, they need to be in the under critical care, and fluid replacement to replace the volume. These are the causes of euvolemic hyponatremia. The most common two are the thiazide-induced hyponatremia and SIAD. In thiazide-induced hyponatremia, patient might be hypovolemic, but also might be euvolemic if they're compensating well. Urine sodium and urine osmolality will be high. Stop the diuretics. We used another medication for which you stopped for the condition for the patient was taking the thiazides for. And then if the patient is hypovolemic or volume down, you can do fluid replacement. They need fluid replacement. Hyponatremia with adrenal insufficiency, there will be feature of adrenal insufficiency, primary or secondary, depending on the cause. If the patient is having classic primary adrenal insufficiency, which is rare, this common cause, is secondary adrenal insufficiency is more common. But if they have primary adrenal insufficiency, they're usually hypovolemic. Compared to the secondary adrenal insufficiency, they are mostly euvolemic, and we discussed that in the previous video. And urine osmolality will be high. Urine sodium also expected to be high, and then if you check the serum cortisol to be low, and you can do the concentrobin test to kind of confirm the diagnosis, and then you do cortisol replacement. Be careful with that and monitor the sodium closely. You don't want to overcorrect because they usually respond really well to steroid or cortical replacement. Hyponatremia in severe hypothyroidism or myxedema, these also associated with increased osmolality or urine sodium, but usually happen again with severe hypothyroidism. Patients usually have other features to suggest hypothyroidism clinically, and you do TSH. TSH will be high. T4 and T3 will be low depending on the cause, and then you treat the underlying cause of the hypothyroidism. In SID, patient usually euvolemic, but they might be mildly hypervolemic, and we talked about why that's the case. And then feature of the underlying cause, and we mentioned there are 4 categories: drugs, malignancy, pulmonary disease, and cerebral disease. Again, urine osmolality will be high, urine sodium will be high. Check TSH to rule out myxedema, expected to be normal, and also AM cortisol expected to be normal. Check the use of cyanide from history. Maybe you want to check cyanide levels and urine too, like diuretic screening. So the treatment of the underlying cause, and then you do water restriction. You can use some oral small dose of diuretics, salt tablets, Vaptans in some cases. And also we discussed the other causes of uh, most likely euvolemic hyponatremia, but these are associated with decrease in both urine osmolality and urine sodium. We talked about the psychogenic polydipsia. Patients usually have, say, underlying psychiatric disease, most likely schizophrenia, but can happen with other diseases as well, psychiatric diseases as well. There's usually excessive water intake, like really excessive, more than 1 liter per hour, and patient might be euvolemic. And then your treatment of the underlying psychiatric disease. Can use antipsychotic or treat the underlying depression or whatever psychiatric condition they have, and then normal diet and water intake. Beer bottomania, there's usually significant history of alcohol use, and most of the cases poor diet as well. Patient might be euvolemic. Again, decrease in both urine osmolality and urine sodium. Advise the patient to stop alcohol and start normal healthy diet. Tea and toast hyponatremia is usually in elderly with other risk factors, with poor salt intake, poor protein intake. They're usually euvolemic. Again, urine osmolality will be low, urine sodium will be low, but usually it's not that low compared to psychogenic polydipsia, for example. Treatment is treatment of the underlying cause, normal diet, fluid replacement if they're really hypovolemic, and also be careful because they might overcorrect, so you need to monitor the sodium closely. So these are the most of the causes that you're probably going to encounter during clinical practice in cases of hyponatremia. All right, very good. So this is the end of the hyponatremia series. So please, if you have any comment, send me an email or write it down in the comments below. And I hope that it was useful. Hyponatremia sometimes can be tricky, and that's why I started my series, Hospitalis Bolus series, with that, and with hypernatremia. Also, let me know what other challenging acute medicine or hospital medicine topic that you want to discuss, and hopefully we will discuss it together, and hopefully we can make it lay it out in a simple way. So thank you all, and I hope I will hear from some of you at least. Bye bye.